Good day, dear great surgeons. Missed you all a lot. Let's have together our microbiology chapter. And by the way, within this chapter, we will be studying the pharmacology and the microorganism side by side within the scope of MRCS, which will be efficient for the exam, God willing. And most of the questions will be recurrent from the records and MRCS scope until the last exam. So let's get familiar with it and do it together. Together we can with the grace of God. First of all, you have to be familiar with the antibiotic mechanism of action. We have many types of action by the antibiotics, like inhibiting the cell wall formation, or inhibiting protein synthesis, or inhibiting the DNA synthesis, or inhibiting RNA synthesis. And you have to be familiar with each family of them. Take them piecemeal along your study. Don't confuse yourself with taking them one shot. So, regarding the antibiotic mechanism of action, the antibiotics which inhibit the cell wall formation, like the penicillins and the cephalosporin, while the antibiotics that act on the protein synthesis inhibition, the aminoglycosides, chloramphenicol, macrolides, tetracyclines, and fusidic acid. And by the way, take care, the aminoglycoside is very famous for their autonephrotoxicity. With each antibiotic, there would be a key word you have to know and understand and keep it in mind, like the aminoglycoside, the gentamicin, having autonephrotoxicity, and you have to be aware of this. Regarding inhibition of the DNA synthesis proteins, the inhibition of DNA synthesis antibiotics, the quinolones like the ciprofloxacin, metronidazole, or sulfonamides, and trimethoprim. Regarding the inhibition of RNA synthesis, the very famous rifampicin, and rifampicin causing red urine. Take this note in your mind and keep it. So if your patient having red urine, it might be due to rifampicin drug intake, or he having bungar. Bungar can cause red urine. Many food and many drugs can cause red urine, by the way. And during COVID, we have all experienced the use of macrolide, whether it was evidence-based or not evidence-based, you did agree with its usage or not. The macrolides act by inhibiting bacterial protein synthesis. If pushed to give an answer, they are bacteriostatic in nature, but in reality, this depends on the dosage and the type of organism being treated. And by the way, the erythromycin, even its name is mycin, was the first macrolide used clinically. It's a macrolide. And the newer examples are the clarithromycin and azithromycin. The adverse effect of erythromycin is a gastrointestinal side effect, and cholestatic jaundice might occur. The risk may be reduced if erythromycin citrated is used, and B450 inhibitor. So again, the macrolide is acting by inhibition of protein synthesis. Don't confuse between the macrolide and the metronidazole. M&M, the metronidazole is inhibiting the DNA synthesis, and the quinolone is inhibiting DNA synthesis, while macrolide is inhibiting protein synthesis. Let's have some notes together regarding the microorganism, like the Fasciola hepatica. And by the way, a very famous question about an enthusiastic watercress farmer, and watercress is gargir. It's a green plant, gargir, in Arabic, if you are not familiar with watercress. He was admitted with a protracted history of severe abdominal pain, fever, and progressive jaundice. Imaging with ultrasound showed mildly dilated bile duct with hyperechoic areas within them. So what is this? It is a viral hepatitis, leptospirosis, Entamoeba histolytica, Clostridium synthesis, or Fasciola hepatica. The only key in this question will be the watercress. He is guiding you towards the fasciola hepatica because it's most classically transported to human through eating watercress. And the ultrasound finding of luminal parasite is classical when he told you that there is a dilated bile duct with hyperechoic areas within them. He is asking you that there is something with this bile duct. This is contributing to the jaundice, and this is the fasciola hepatica. So, the fasciola hepatica is also known as the common liver fluke. It's a parasitic trematode. Inhabitate the liver, loves the liver, and the liver loves it. So, infection of the human is a part of the plant or the food trematode infection and found throughout the whole world, by the way. There are two illnesses phases. During the acute phase, the immature worm will begin penetrating the gut, causing symptom fever like nausea, swollen liver, skin rashes, and extreme abdominal pain. While the chronic phase occurs when the worm is mature within the bile duct and can cause symptoms of intermittent pain, jaundice, and anemia. Diagnosis is either by stool sampling or serology, and the treatment will be by triclabendazole, and some patients may need ERCP. So, this case in the exam might be confusing. You are now creating your own monster. How I should know if this patient is obstructive jaundice due to a fasciola or anything else? There will be a guide in the exam, like the watercress. So take every word within the scenario a guide for you. Don't create your own monster. It will be clear in the exam. Again. A very common trick in the exam, he will be giving you a very long scenario indicating the patient was old, having many comorbidities, and having kaza, and having etc. And the last line the question will be irrelevant, direct, simple question, doesn't relate to the whole scenario. You have been reading a scenario that took you about 10 minutes, and we don't have this much time in the exam. You have only 1 minute to read and answer. There is no thinking. You have to think while reading. You have to make your decision within 1 minute and take it. So take care and read the last line. If it's a separate question, go for it and answer it. If it's not separate question, so run with your eye along the whole scenario and mark up your mind and take your decision and answer. And the very first answer come to your mind will be most probably the most correct, right answer you deserve in this exam. So no worries by now. We are training. If you're having this trap, you will not get trapped in the exam because you have been training all along for it. And again, sharing is the most important critical pillar during your study. You will learn from each other. You'll learn from each other point to improve, and sharing will keep you updated and revise your answer at least 5 times. The very first time when you read and knew that you have a point to improve in this question. Second time when you take the decision to take it a screenshot. Third time when you share it. Fourth time when others interact for your sharing. And the fifth time when you read and interact with your friends regarding what you shared. See, a simple idea you have revised 5 times with your subconscious by just taking the decision to share it. So share and you will gain. Dear great surgeon, regarding the food poisoning, take care from the timing of the food poisoning incident, and it will guide you in the exam regarding which organism is the causative cause for the food poisoning. He will tell you that at a young age admitted with a crampy abdominal pain and diarrhea. He attended a large wedding earlier in the day. So at the beginning of the day, he had a wedding. Looking forward to attend all your wedding, God willing. You all deserve the best. So, several other guests also affected with the same illness. So, it's the food in this wedding. But in your wedding, you have to be cozy and choose a nice, trendy food. Nobody wants his wedding to be a cause of food poisoning, of course. unless the groom is poisonous. So, which of the organisms will be likely to be accountable and the causative organism for this food poisoning? According to this scenario, earlier this day, and the whole wedding got the crampy abdominal pain and diarrhea, this is Clostridium perfringens. The Clostridium perfringens is a common cause for food illness poisoning, and its ability to form spores may make it relatively resistant to cooking. So it's nobody's fault for now. It's not the groom. The timing of the onset would favor Clostridium perfringens because it evolved within several hours, while the Staphylococcus aureus poisoning will be occurring more sooner. So take care from the timing. If I want to focus on something regarding the Staph aureus, it's a facultative anaerobe, not strict. It's a facultative anaerobe, gram-positive, catalase positive, and cause hemolysis on blood agar. And by the way, 20% of the population are long-term carriers or carriers for staph. It's on our own skin. And it's the most common cause for cutaneous infection for this reason, like an abscess, for example. Dear great surgeon, take care. Whenever you do a blood culture and grow a positive cocci like Streptococcus bovis especially and causing septicemia, think of the carcinoma of the colon. And by the way, it can cause endocarditis. But here we have a question. The endocarditis caused by Streptococcus bovis, it's over a native valve or a synthetic metal valve? This great surgeon, take care that endocarditis on a native valve vegetations, this is most caused by Streptococcus viridans. But if you found the Streptococcus bovis, we are talking about a cancer colon suspicion along with the endocarditis. But when we have endocarditis over a prosthetic valve, this is most probably will be a staph epidermidis. Keep it in mind, you will be asked it. It's a very common recall exam. So endocarditis on a native valve, on a natural valve with vegetation, it's caused by Streptococcus viridans. And if you found bovis, it will be leading you that the patient might have cancer colon. And the question might be reversed. He will tell you he's a cancer colon and having endocarditis. Think of the Streptococcus bovis. And if we have an endocarditis over a prosthetic valve, the most common organism will be causing over a prosthetic metal valve, the staph epidermidis. And by the way, remember that the auscultatory site where you hear the valve is not the same as the anatomical site of the valve. They are not the same. And take care, the question might be manipulated in the exam and not asking you about the organism, but ask you about where you hear it or where the valve is found. Dear great surgeon, take care. A very famous question in the exam regarding the Fournier gangrene, and he will present to you the patient asking you about either it's involving the scrotum and the testicle or not. And of course, Fournier gangrene doesn't involve the testicle, it only involves the skin and the fascia. So he will ask you about a diabetic old patient of an area of necrosis of the perineum and the base of the scrotum. Take care. The testicles are spared in Fournier gangrene. Again, there is some surrounding erythema. He is systemically unwell and hypotensive. And asking you about the organism causing this Fournier gangrene. Of course, it will be E. coli and bacteroids. And the other question will be, is it sparing the testicle or not? Yes, it is sparing the testicle. And by the way, Fournier gangrene, it's a serious because it's a cause and a result from necrotizing fasciitis. Fournier gangrene, necrotizing fasciitis affecting the perineum. And it's a polymicrobial with E. coli and bacteroids. What is necrotizing fasciitis? If you are not familiar with this term, it's an advancing soft tissue infection associated with fascial necrosis, the fascia. It's uncommon, but can be fatal if happen, and you have these suspecting the necrotizing fasciitis whenever it occurs. It may, in many cases, there is underlying background of immunosuppression, like diabetes, for example, and caused by polymicrobial flora, aerobic and anaerobic, and even MRSA is seen increasingly in cases of necrotizing fasciitis. So, we agree that necrotizing fasciitis is very serious, and in the perineum it's called Fournier. And to be familiar with other term, when it's occurring in the trunk, we call it melanin gangrene. Melanin gangrene is similar principle of the necrotizing fasciitis, but the infection is more superficial sided than necrotizing fasciitis and often confined to the trunk. And the clinical feature of the patient in the Fournier, Melanin, or even necrotizing fasciitis will be fever, pain, cellulitis, edema, induration, numbness, and the late finding will be, if you left the patient neglected, purple black skin discoloration, blistering, and hemorrhagic bully. You will find the bully hemorrhagic, black. If you found the patient edematous and with black bully, it's not anasarca due to heart condition. It's a gangrene. It's necrotizing fasciitis. If you felt the crepitation, you are talking about a gas gangrene. It's called a dirty dish water fluid discharge. Literally, dirty dish water fluid discharge. زي الترنش لو بتتكلم عربي. So this patient will be, of course, having his fastest route towards septic shock. So keep in mind, necrotizing fasciitis is very serious condition. And to manage the necrotizing fasciitis will be debridement. Radical surgical debridement is the cornerstone of management of necrotizing fasciitis as early as possible. And you have to be having a sterile, not just saline, but a sterile dressing is used to dress the wound. And you will find your friend of plastic surgery. I am willing to help you all regarding is considered once the infection is completely treated. So treat the infection and call plastic surgeon to reconstruct the whatever the necrotizing fasciitis have done to this poor patient. Most of the causes of the diarrhea by the end of the day will be with Campylobacter jejuni. But if we have an HIV patient or renal transplant patient, immunocompromised patient with diarrhea, think of Cryptosporidium. Although the diarrhea normally it's a self-limiting disease or self-limited incidence, this is not the case in the immunocompromised individual who can develop severe illnesses, and the organisms that can cause the diarrhea will be Salmonella, Shigella, Campylobacter, but in the immunocompromised patient mostly will be Cryptosporidium. As we brought up the diarrhea, when some doctors give the patient the medication with a very famous antibiotic and the patient asks him that he has a bowel habit different than normal and having a diarrhea, for God's sake, think of Clostridium difficile due to clindamycin. Take care. Many antibiotics and broad spectrum antibiotics might cause Clostridium difficile. Whatever operation is done and whatever antibiotic is done, when the patient coming to you with diarrhea like and normal vital stable in all other symptoms, and the only symptom is coming to you with disturbed bowel habits due to foul smelling diarrhea and chronic abdominal pain, suspect the Clostridium difficile. The exam, the Clostridium difficile might come with any broad spectrum antibiotic, especially clindamycin or even ciprofloxacin. He will give you the key in the question and stress on it. So, the Clostridium difficile will cause pseudomembranous colitis, which adds a yellowish plaque form over the damaged epithelium. Pseudomembranous colitis, Clostridium difficile with broad spectrum antibiotic. Take care. Loose watery diarrhea like is very specific for Vibrio Cholera. So, Vibrio Cholera is a serious illness because it can cause severe dehydration and even death. You all remember The Love in the Age of the Cholera. It's a very famous movie, by the way. It discussed the cholera epidemic. So, Vibrio cholera is a short gram-negative route transmitted by contaminated water, seafood, and the symptoms include sudden onset of effortless vomiting and profuse watery diarrhea. This is the key. Watery diarrhea is very specific for Vibrio cholera. And correction of fluid and electrolyte loss are the mainstay of the treatment. You have to prevent this patient from going through dehydration. Most of the cases will resolve, and antibiotics are not generally indicated in Vibrio cholera. The rule is very limited. So again, the passage of very loose watery diarrhea like stool distinguish cholera. Most gastroenteritic infection doesn't produce such watery motion like Vibrio cholera. We agree that watery diarrhea is specific for cholera, and its source will be infected water or infected seafood. But if a patient is in the hospital and developed watery diarrhea, profuse, of course it's not cholera. There is no cholera within the hospital. The patient is supposed to enter the hospital to be having his medication and the treatment, not to give him infected water and give him cholera. But what can occur? Take care from the scenario. He will tell you that he is in the recovery of the hospital following an operation, for example, a total hip replacement. So he had been in the operation for some time and developed a profuse watery diarrhea. So he is telling you as well that the patient have been suffering from the similar symptom. The patient in the same ward he is admitted to having the same symptom. What this could be? This is Clostridium difficile. It can spread rapidly on the surgical ward, and the use of the broad spectrum prophylactic antibiotic during arthroplasty can increase the risk. This is the trick. I know it's a very mean question, but it's a tricky as well. If he meant to say to you it's a cholera, he will state it and doesn't include Clostridium difficile in the options. But if you found Clostridium difficile in the options in a patient in the ward in the hospital, it's not cholera, unless he is being treated from the cholera itself. And by the way, to your imagination, do you understand that the Clostridium difficile within the healthcare facilities is by person to person through the fecal-oral route? This is the mode of transmission. Yes, so the healthcare providers like us transiently are contaminated with Clostridium difficile spores. So take care. And another trick regarding the Clostridium difficile, it's not only fecal-oral route and person to person. It has spores, so might also be spreading through the air route. So God save us all, the healthcare worker providers. Good day, dear great surgeons. Let's have some microbiology chapter void shots and revision together. Together we can with the grace of God. Missed you all out really. Don't confuse the Ascaris lumbricoides and ankylostoma. They may seem same, but they are way more different. Infection with Ascaris lumbricoid usually occur after individuals who have traveled to places like the sub-Saharan Africa or Fast East. Unlike the ankylostoma duodenal infection, there is usually evidence of both worm and eggs in the stool, and the absence of pruritus, if there is no itching there, makes the enterobius vermicularis less likely because the main symptom presenting with the enterobius vermicularis will be itching and most common with the children. And you will find the pinworm of the enterobius vermicularis around the anal canal. It's very specific look. If you see it once in your life, you will never forget it. Literally, worms, pinworms, white worms infiltrating the anal canal. Very disgusting, but it's unforgettable event if you see it. And the presence of coughing may be due to the migration of the larva of the Ascaris lumbricoides within the lung. The Ascaris lumbricoides is a very funny, naughty parasite. It can go everywhere and can cause many manifestations and can block any tube within your body. So, the Ascaris lumbricoides is due to infection with the roundworm, which is called Ascaris lumbricoides, and infection begin in the gut following ingestion, then penetrate the duodenal wall to migrate to the lung, and cough may be manifesting. This manifestation of coughing means it infiltrated the lung, and the cycle begins again with the ascariasis. The diagnosis is made by identification of the worm or eggs within the feces and treatment with mebendazole. And again, it can cause any blockage to any tube within your body. It can even cause obstructive jaundice or even intestinal obstruction. This is Ascaris, the funny, naughty parasite. Regarding the Ankylostoma duodenale, it's a hookworm that anchor the proximal small bowel. Most infections are asymptomatic, although may cause iron deficiency anemia. That's why whenever you find anemia within any patient, you have to search for the cause. Never deal with the anemia that this patient is chronically anemic. Yes, why it's chronically anemic? He has been known to be anemic along his life, doctor. Yes, for what? It might be even a simple cause like parasite, which will be treated with mebendazole like Ankylostoma duodenale. So, most of the infection of Ankylostoma duodenale might be asymptomatic, and the very first manifestation might be iron deficiency anemia. The larvae may be found in the stool left at ambient temperature. Otherwise, infection is difficult to diagnose. So, keep it in mind so you can find it. Infection occur as a result of cutaneous penetration. It migrates to the lung and cough up and then swallow again. Treatment will be mebendazole. So, Introbius vermicularis, Ankylostoma duodenale, Ascariasis, all of those with different presentation, different species of parasites, they are treated with mebendazole. And regarding the Introbius vermicularis, we are all agree now it's more common to be presenting with pruritus ani. He will be itching his anus. And diagnosis usually made by placement of scotch tape at the anus. If you didn't find the Introbius vermicularis pinworm in the anus at this time, put a scotch tape and you will find that in this scotch tape will be finding the larvae, the eggs, and the Introbius vermicularis pinworm. And again, the treatment will be mebendazole. We have talked before that there is a watery diarrhea which is specific for cholera, and this can occur with Clostridium difficile, but Clostridium difficile more common to be hospital acquired or due to malpractice and using of abuse of antibiotics. But diarrhea brought up to me a protozoal cause like the Giardia. The Giardia diarrheal infection caused by the Giardia lambili infection occur as a result of ingestion of the cyst, and symptoms are usually gastrointestinal with abdominal pain, and there will be a bloating, passage of soft, loose stool. The diagnosis will be serology and stone microscopy, and the first line of treatment of Giardia will be metronidazole. Another cause of diarrheal protozoa origin, like the Cryptosporidium. The Cryptosporidium symptoms will be diarrhea and cramping and abdominal pain, and it will be identified by the cysts that might be identified in the stool. And the organism produce cysts which are excreted and thereby cause new infection, and the cycle goes on. And also the treatment of the Cryptosporidium will be with metronidazole. So apparently diarrhea is very serious symptom, and when someone tell you diarrhea now, you have many light bulb in your mind about many differential. You have to be having the keys to every one of them. This great surgeon, there is a very famous scenario in the MRCS exam regarding a man from the UK returned to India or returned to Egypt or any country of our great countries. They are not used to our food. Their stomach are weak. So they can't withstand our hepatitis A infection. So he will be presenting with painless jaundice. On examination, it's not deeply jaundiced and there is no organomegaly. This is infective hepatitis, and most likely cause is that he traveled to a developing infectious hepatitis, of which hepatitis A is most common habitat. So embrace yourself. You are immune against all of this. So, being jaundice due to travel, he might be infected with hepatitis A infection. The painless jaundice reminds me of the total parenteral nutrition associated jaundice, the non-calcular jaundice, which is usually follow long-term use of painless non-obstructive feature, so often due to hepatic dysfunction and fatty liver, for example. Remember and keep it in mind that TBN associated jaundice, the long-term using of total parenteral nutrition can occur and can cause non-calcular jaundice, which is painless usually and non-obstructive feature, by the way. Another very famous painless jaundice will be pancreatic cancer. Pancreatic cancer is usually typically painless jaundice, but with palpable gallbladder, and this is the Courvoisier law. Courvoisier law stated that if you palpated the abdomen and felt the gallbladder and the patient is jaundiced, he will be all of jaundice. But painless, he is complaining of no pain. This is pancreatic cancer until proven otherwise. So it's due to direct occlusion of distal bile duct or pancreatic duct by a tumor. And sometimes it's a nodal disease as a portal hepatitis and may be a culprit, in which case the bile duct may be of normal caliber. So remember, if you have pain, fever, and jaundice, this is a Charcot's triad. This is not pancreatic cancer. This is cholangitis, an ascending infection of the bile duct, and usually will be with E. coli, by definition occurring in a pool of stagnant bile. Use great surgeon. Again, take care from the not true trap. It's like at least the trap. All those traps matter in the exam. And regarding the the E. coli, it's a gram-negative organism, most commonly transmitted by the consumption of contaminated food, and it may be complicated by microangiopathic hemolytic anemia, and the plasmids typically confer antibiotic resistance. But take care, it can cause hemolytic uremic syndrome, but typically this complication develops with the children, not the adult. Take care and keep it in mind. The hemolytic uremic syndrome and thrombocytopenic purpura with the O15-7 strain, the enterohemorrhagic with the E. coli, is in children, not in adults. Oncoviruses are important in the exam. They are the viruses which can cause cancer. They may be detected on blood test and prevented by vaccine. These are the main types of oncovirus you have to be familiar with, like the Epstein-Barr virus, the human papilloma virus, as well as the human herpes virus A, hepatitis B, and the human T lymphocytic virus 1. We have to stand some time for Epstein-Barr virus because it's associated with many viruses, with many cancer. The Epstein-Barr virus associated with Burkitt's lymphoma, Hodgkin lymphoma, post-transplant lymphoma, even nasopharyngeal carcinoma. So keep this in mind. While the human papilloma virus is a notivirus concerning with the cervical, anal, penile, vulval, and even the oropharyngeal cancer. It's a notivirus, the human papilloma virus, and it doesn't need any explanation how naughty he is. He's not trendy at all. He is concerned with the cervical, anal, penile, vulval, and even the oropharyngeal cancer, human papilloma virus, while the Epstein-Barr virus is more trendy. He is concerned with the Burkitt lymphoma, Hodgkin lymphoma, post-transplant lymphoma, nasopharyngeal carcinoma. And here is the trick. The Epstein-Barr virus with the nasopharyngeal, while the human papilloma virus with the oropharyngeal. And keep it in mind. If you remember that the human papilloma virus is concerned with all sexualities like the cervical, anal, penile, vulval, and oropharyngeal, you want to forget and confuse yourself with the nasopharyngeal with the Epstein-Barr and the oropharyngeal with the human papilloma virus. And no doubt we all familiar that the hepatocellular carcinoma will be associated with hepatitis B and hepatitis C viruses, while the Kaposi sarcoma is common with the HIV or the human herpes virus 8. Take care. The human papilloma virus 16/18, which is the naughty virus, while the human herpes virus with the 8, it's a Kaposi sarcoma. And keep in mind that the human T lymphotrophic virus 1 associated with the tropical spastic paraparesis of the adult T cell leukemia. So adult T cell leukemia with the human T lymphotrophic virus 1. And as a side note, as we brought up the lymphoma, let's remember that Hashimoto thyroiditis can be complicated to be a lymphoma. It's a very rare complication, but yet can occur. And now let's move on to gangrene. Gangrene, we have three types of gangrene. We have dry gangrene, wet gangrene, and gas-forming gangrene. When he tells you that there is a gangrene stool, if it's a dry gangrene, please search for the cause and know if the patient can be revascularized or not, because there is no amputation or debridement before revascularization. Except if it's a wet or gas forming gangrene, you have to save the patient life from the toxins which produced by this wet or gas forming gangrene. Gas forming gangrene means the patient is immunocompromised or even neglected patient. Both are the same result, will be a gas forming gangrene, and it will be manifested with very offensive specific odor. Offensive odor. You can't withstand to take your own breath within an open air even, and it will be very offensive, and when you palpate it, it will be forming crepitations. You will find a crack below your fingertips. This is gas forming gangrene. So the gas forming gangrene is formed by the Clostridium difficile bacteria. It's a deadly form of gangrene, and you have to deal it fast or you will lose the patient because of this gas gangrene and will enter septic shock. We all now agree that we have the Clostridium difficile to be causing the gas gangrene while having an offensive odor. But with difficult appendectomy as well, we will have a very pungent aroma, a specific awful smell after appendectomy. This is due to the bacteroid fragilis. The bacteroid is commonly present in severe peritoneal infection as it's facultatively anaerobe and may present in the pus post-appendectomy. Now let's be familiar with the amoebic abscess. The liver abscess is the most common extraintestinal manifestation of amoebiasis, about 75% to 90% of the lesion within the right lobe of the liver, and the presentation of the patient will be including fever, right upper quadrant pain, and it can be diagnosed only by ultrasound at least. It's not manifesting clinically with jaundice always. It might be only fever and upper quadrant pain, right upper quadrant of course, and the ultrasound will give us a hint that there will be a cavity filled with fluid and poorly defined boundaries. So there will be always a fluid filled structure with poorly defined boundaries. Aspiration is the mainstay to treat this. So it will be treated with metronidazole, and aspiration can be done. There is no exploration for amoebic abscess in the liver. So amoebic abscess in Amoeba histolytica in the right lobe of the liver, and manifestation will be fever, right upper quadrant pain, plus or minus jaundice. The ultrasound will show a poorly defined boundaries filled with fluid, and aspiration will show anchovy-based consistency, and the treatment will be metronidazole. There is no need for surgical intervention. There is no need of surgical intervention in amoebic abscess. Reminds me of pancreatitis. You have to know the pancreatitis and define it clinically to understand well that pancreatitis has nothing to do with it surgically. It's for conservative management. Even pancreatic necrosis is the only source and the only reason you can explore the pancreas for, that you have to be aspirating first the fluid and make sure from cytology that this is a pancreatic necrosis. So we have to understand before going for surgery, because many diagnoses are made for just conservative management. And you have to understand when to intervene and when to not intervene. Because, for example, the hydatid cyst, a very high differential diagnosis for the amoebic abscess. No one want to rupture a hydatid cyst within the peritoneal cavity. He will kill the patient with hypersensitivity, because hydatid cysts are seen in cases of echinococcus infection, and typically an intense fibrotic reaction occur around the site of the infection. The cyst has no epithelial lining, very high differential for the amoebic abscess or any liver cystic disease. Very characteristic in real life to diagnose the hydatid cyst with the multiple daughter cysts within the major main cyst. And by the way, the hydatid cyst patient will come to you with fever, right upper quadrant pain, malaise. Secondary to the bacterial infection occur in 10% of the cases of hydatid cyst. And the liver function tests are usually abnormal, and eosinophilia might present in 33% of the cases. And the ultrasound will show you the septi and hydatid sand or the daughter cyst as well. This will be specific from the amoebic abscess, which is ill-defined structure filled with fluid, while the hydatid cyst will show multiple septation with multiple daughter cysts. And of course, percutaneous aspiration was previously contraindicated. It's not incorporated into some treatment regimen because of fear of hypersensitivity reaction can occur from the hydatid cyst. Treatment is by sterilization of the cyst with mebendazole and may be followed with surgical resection and even a hypertonic swab or bagged around the cyst during the surgery. Some theories can inject alcohol within the cyst to to kill the daughter cyst and the parasite within it, the Echinococcus granulosus. So we brought up that the issue of the amoebic abscess, there is no surgical exploration for liver abscess, but there are some abscesses in our body that never wait for fluctuation, like the breast, the brain, and the fillon in our fingertip never wait for fluctuation because they are closed spaces. So never wait for fluctuation in the places start with a B: the breast, parotid, the palm, and perianal abscesses. Because the breast abscess, if left for fluctuation, it will cause lactiferous duct destruction, and the parotid abscess is left and waited for fluctuation, it will cause facial nerve destruction. The palm abscess is left. If left, it will cause fine nerve destruction, and it's a closed space infection will destroy every soft tissue within the palm. And the perianal abscess, if left for fluctuation, it will cause anorectal fistula, and nobody wants a fistula in his anus, by the way. And remember that we have the amoebic abscess of the liver and the brain abscess as well as the cold abscess. They must be aspirated. ABC Aspiration, amoebic brain cold abscess. Cold abscess of TB. It's not cold and it's not an abscess, by the way, because it's caseous necrosis. We will get to it soon. As long as we brought up the abscesses, let's be familiar with the very famous scenario that can face you in real life in the ER. A very common scenario to have a drug abuser coming to you with a groin pain, a severe groin pain. This is due to a groin abscess, and this groin abscess must be in your mind as a false aneurysm due to several self-injection of the drug abuser with the drug in his groin. It's not a normal abscess, and you have to consent the patient and his relatives due to the possibility of being this a false aneurysm that can cause a torrential bleeding and requires patching of the femoral artery or the femoral vein. Keep this in mind. And the drug abuser must be tested for all known sexually transmitted or intravenous transmitted viral disease like hepatitis C, hepatitis B, and HIV, and whatever viruses you are familiar with. Do him a full profile and save yourself. And very common to be in the drug abusers, the hepatitis B. Hepatitis B is a double-stranded DNA virus that is spread through exposure to infected blood or body fluids, including vertical transmission even from mother to child. The incubation period is 6 to 20 weeks. Immunization against hepatitis B contains hepatitis B surface antigen, which is absorbed onto the aluminum hydroxide adjuvant and is prepared from the yeast cell using recombinant DNA technology. Most schedule get 3 doses of the vaccine with recommendation for one of booster 5-year dosage following the initial primary vaccination. At the risk group who should be vaccinated include us. We are the healthcare workers and of course the intravenous drug users. You have to vaccinate them to can intervene and take their drug safely. And of course the sex worker if you are in a free country, and the close family contact of the individual with the hepatitis B. Individuals receiving blood transfusion regularly might include to be a risk group who require vaccination as well as the chronic kidney disease patient who might soon require renal transplantation or replacement therapy, even prisoners and the chronic liver disease patient. And take care, around 10 to 15% of the adult fail to respond or respond poorly to the 3 doses of the vaccine. The risk factor include age over 40 years or obesity, smoking, alcohol or excessive or immunosuppression. Take care. Testing for the antihepatitis surface antigen is only recommended for those at risk of occupational exposure, like us, the health workers, and the patient with chronic kidney disease, and the patient of anti-hepatitis B surface antigen should be checked 1 to 4 months after the primary immunization. And remember, from the very serious complication of hepatitis B will be glomerulonephritis, pruritus nodosa, cryoglobulinemia, and chronic hepatitis, as well as fulminant liver disease. But this is not the real thing we fear of. We all fear of hepatocellular carcinoma. And to manage hepatitis B, biglycated interferon alpha is the only treatment available. So never forget that hepatitis B is double-stranded DNA virus while the hepatitis C is RNA virus. Both can cause hepatocellular carcinoma, by the way. There is no vaccine for hepatitis C, by the way. We only have hepatitis B vaccination up to now. And take care, hepatitis B is associated with polyarthritis nodosa. Again, polyarthritis nodosa is associated with hepatitis B, while porphyria cutaneous tarda and cryoglobulinemia is associated with hepatitis C. If you are not familiar with the hepatitis viruses, we have 4 main famous hepatitis viruses. A, B, C, and D. Hepatitis virus A is due to ingestion of contaminated food and water, while B, C, and D is due to parenteral contact and contaminated body fluids. A is acute, B can be acute or chronic, C is chronic, D is acute or chronic. Hepatitis A rarely results in chronic liver disease, usually fulminant hepatitis, and can go, while B can cause fulminant hepatitis or even acute liver failure and can cause hepatocellular carcinoma on long term, P and C, or even D. And the point of the groin abscess reminds me again with the necrotizing fasciitis. So, necrotizing fasciitis is mainly polymicrobial and immunocompromised. So, the drug abuser mainly will be immunocompromised. Even his groin abscess might be a pseudoaneurysm, but take care, it can be an abscess and can go to be necrotizing fasciitis. So it's a polymicrobial feature may include dirty dishwasher fluid within the wound, and the presence of crevices is needed to make the diagnosis of the necrotizing fasciitis, and muscles are relatively spared. But take care never to attempt primary closure after the initial debridement of necrotizing fasciitis, whatever it costs. You have to make sure it's clean, otherwise, you are forcing the patient to be in a vicious circle of necrotizing fasciitis that never ends. And by the way, the crepitus within the necrotizing fasciitis is present only in 35% of the cases, so don't wait for crepitus to make diagnosis of necrotizing fasciitis. Therefore, the absence shouldn't exclude the diagnosis of necrotizing fasciitis. Save this patient for the God's sake and debride the patient. Dear great surgeons, take care. We have streptococcus with two main types, the alpha hemolytic streptococci and the beta hemolytic streptococci. And the beta hemolytic streptococci have two types, group A and group B. So regarding the streptococci, alpha and beta, the alpha is the most important. Alpha hemolytic streptococci is Streptococcus pneumoniae, and Streptococcus is common cause of pneumonia. From its name, it's Streptococcus pneumoniae. What can it cause? Of course, pneumonia. So, Streptococcus pneumoniae or alpha hemolytic streptococci can cause pneumonia, meningitis, otitis media, and other clinical example will be Streptococcus viridans. But regarding the beta hemolytic streptococci, we have group A and group B. The group B is the Streptococcus agalactica, not like Agalacticus in Marvel universe. No, Streptococcus agalactica in the microorganism universe that may lead to neonatal meningitis and septicemia, and this is serious by the way. But regarding the group beta hemolytic streptococci, group A, the most common organism important is Streptococcus pyogen, responsible for erysipelas, impetigo, cellulitis, type 2 necrotizing fasciitis, and pharyngitis, as well as tonsillitis. So, tonsillitis, erysipelas, impetigo, cellulitis, all why Streptococcus pyogen, which is beta hemolytic streptococci group A. It can ask you about the group, it can ask you directly about the pyogen itself, the Streptococcus pyogen, or ask you what can it cause, or the commonest organism for erysipelas, it's Streptococci pyogen. What is the commonest organism for impetigo? Streptococcus pyogen. What is the commonest organism for cellulitis? Streptococcus pyogen. Tonsillitis, Streptococcus pyogen. Immunological reaction can cause rheumatic fever or post-streptococcal glomerulonephritis, and this is serious by the way. At last but not least, the erythrogenic toxin can cause scarlet fever, not Scarlett Johansson. Scarlet fever can be caused by group A beta hemolytic streptococci, which is very important. And take care. Penicillin is the antibiotic of choice for group A streptococcal infection. So, the most common organism affect previously abnormal heart valve, native valve will be Streptococcus viridans, and if you found the bovis search for cancer colon, and if you found a metallic valve, we are talking about epidermesis.